insomnia. This is the practice parameter on sleep, right?
Yes.
I can tell you the bottom line if we want to get to where we're at as you're reading this, because I'm not going to read the slides, is that the evidence base is very poor. Melatonin has the most evidence and it's modest at best. And then after that, the evidence base is very weak, very mixed, weak. But you'll see as we get into our recommendations, I did make a couple of changes and I wanted to bring that up for discussion here and see what you all thought because of all the requests from the different practitioners out in practice, right? Setting the realistic goals, the typical starting low, clarify with the families as to whether that, if you're going to recommend melatonin, whether it should be as needed or on a continuous basis and what the possible discontinuation parameters would be, and that the selection. And then Marie's program's having Dr. Neubauer give a presentation on insomnia, a webinar next week on adults. And I went and with that old adage of good people copy, great people steal, we kind of stole this slide from his slide deck for a presentation here. And you'll see that there isn't a lot of support, and there isn't a lot new to update in this section as well. In children and adolescents, still melatonin has the most amount of studies. I tried to keep mostly this is in the general population. I didn't review the neurodevelopmental disorder, the ASD-ID population or the ADHD population, where there's a whole other set of literature on that. And Regina, maybe you can talk about that. In clonidine, again, there's nothing new. And this is mostly in the neurodevelopmental and the ADHD population. And it's not as robust at all, but you'll see in a second people say, hey, you're just recommending melatonin. What do we do if that doesn't help? What do we do? What do we do, right? And then diphenhydramine. There's still that one study by Russo and colleagues in 1976, that one randomized controlled trial that showed that it did help, but not much either. But it is the most, well, actually melatonin is kind of creeping up as the most recommended, and follow. They're hand in hand if you look at a few of the more recent surveys, right? All these others are off-label, and only these two have had randomized controlled trials, and both did not show any significant change in either in sleep latency or duration of sleep as well. Again, we're talking about for more insomnias and not the parasomnias in this population, right? So this was the previous table. So one of the questions is whether we should still maintain this information in those tables, because again, we discussed last time that practitioners ask, gee, what if we've tried this and it hasn't helped, and what if we've tried that and it hasn't helped? And even though you'll see in a second we're not recommending it, we included some of that data in the tables, right? And that's it, I'll stop there.